Good, we're live. Well, thank you all for inviting me back here. Last time I was here a couple of years ago was before my little attempt to die. And so it somewhat changes your view on life. And Vinay was kind enough to invite me back to tell you a little bit about what it's like to be involved in setting up a system that, interestingly enough, and luckily enough, helps to save your life one day. And so one of the messages that I want to sort of emphasize is, who's the most important person to know CPR and to know about your EMS system and to help improve in whatever way you can, whether you're a healthcare professional or a lay person or anything in between in terms of, a technical person who builds devices for us or helps to develop drugs. Whatever your role, who's the most important person? It's you, and it's your family, and it's your friends. Because if someday, God forbid, something happens to one of you, as it has for many of our wonderful survivors who are here today, it may be that very individual who plays a critical and pivotal role in helping to save your life. So you've heard a little bit about my background from Vinay. I'm not going to elaborate on it, but I want to emphasize the fact that I've been privileged, along with a fellow who's here today, Jerry Overton. I'm singling him out because there he is. Jerry and I played a bit of a role over the last, 30 some odd years in helping to get a EMS system off the ground, in our case in Richmond, Virginia. And what is really interesting, and part of my message, is that some lives can be saved with a brief period of CPR and defibrillation. Some lives require additional therapies, such as drug therapy, a trip to the ICU, in some cases a surgical procedure, an angioplasty. But in some cases, today, lives that yesterday couldn't be saved can be saved with more advanced procedures. Procedures that in a handful of our communities and in emergency departments can be done very rapidly and very expertly. And the one that I'm going to talk about today is the one that I actually had to take advantage of, which is the use of heart-lung bypass, sometimes called ECMO, in the emergency department in someone whose heart has stopped beating. Now, my case is a little bit different than many of the survivors. I've been a healthy guy my whole life. I've been privileged to be born into a family where my relatives have all lived into their 80s and 90s. Sometimes, if you get lucky and can pick your genetic heritage, that's certainly not a bad thing. And one of my hobbies in life is shown here. And I'm very proud of the fact that I worked my way up through the ranks from flying little Cessnas all the way to my means of transportation, which is flying a little prop jet. Now, why am I mentioning this? Because in order to be given the privilege by the FAA of being allowed to fly, you have to pass and continue to pass and repeatedly pass medical examinations, and that's a good thing. That's a very good thing. And I passed them all with flying colors. God bless, the fact that I've been very privileged in that respect. And suddenly, I'm going to tell you a couple of the details shortly. I found myself the victim of a thing called a pulmonary embolus. Now, in lay terms, that's a blood clot that forms somewhere in the body. Usually, it forms in the legs, but sometimes it can form in the veins elsewhere in the body. It affects hundreds of thousands of people in this country and countries like us throughout the world. It's actually the third most common cause of cardiovascular death after coronary disease and stroke. About 20% of people who die, typically in a hospital, of a variety of conditions and have an autopsy have blood clots in their circulation at autopsy. And in about 3/4 of them, It's actually their main cause of death. In some cases, cardiac arrest. We estimate that as high as 20%, 1 in 5 of cardiac arrests that occur out of the hospital in adults may be occurring because a blood clot forms and suddenly breaks loose from the veins and goes to the right side of the heart and plugs up the blood flow from the right side of the heart to the lungs. Well, if blood can't get into the lungs, it can't pick up oxygen. And if blood can't get into the lungs, the blood pressure drops to very low shock type levels, or worse yet, actually causes the heart to stop. It affects men and women approximately equally. And that's what happened to me out of the blue. Blood clots can be very tiny, and in some cases actually fly from the veins in the leg into the chest, and you never even know it. You may get a little racing of the heart briefly or a little shortness of breath. They may be a little bit more massive, in which case you do get symptoms, you get very short of breath, or they may be actually quite massive and suddenly throw you into shock. And it all depends on how big the blood clot is and how much of the blood flow to the lungs is suddenly cut off. If a big blood clot goes through the right side of the heart and blocks up the right and the left lung, we call this a saddle pulmonary embolus. And if that happens, if there's a little trickle of blood, the patient can remain conscious, at least for a short time. If it's a total occlusion, they don't remain conscious at all, and they're in cardiac arrest, just like many of the stories that some of you can tell. This are survivors who are here at this meeting. So here's what happened to me. In September of 2014, suddenly developed some pain on the right side of my abdomen, simple kidney stone. Went to the urologist, took an x-ray. Joe, you got a really small stone on the right side. You're going to pass it in the next couple of days, just like most people do, no problem. Are you sure your pain's on the right side? Yeah, I know my right and my left. What do you mean? Well, come here, look at your x-ray. And my x-ray showed a little tiny stone, a little pebble on the right side, blocking the flow of urine from my kidney to my bladder. And on the left side, there's a big kidney stone about the size of a golf ball. Huh? What's that all about? No symptoms, no nothing. Well, I sure enough passed that right-sided stone a couple of days, no problem. And then the question is, okay, what do we do about this stone on the left side? Well, the FAA, thank you very much, very appropriately, doesn't like it when pilots have stones that are sitting in their kidney that at any time could block the flow of urine from that kidney and cause pain. You don't want your pilot to suddenly have pain in the cockpit. And so the question was, okay, now what do we do? And the answer was, well, we can do major surgery on you and try to get that golf ball out. And oh, by the way, you got about a 10% chance that you're gonna lose your kidney. What else you got? Okay, we can have you come in once a month for a procedure called lithotripsy. Some of you have had that procedure, it's pretty common. And what's done is you get knocked out with anesthetics for about 45 or 50 minutes. And while you're out, there's a special machine that they place up against the side of your body that the stone is on, and it basically shakes the heck out of you for about 35 or 40 minutes. And what it does is it breaks apart the stone, and over the next couple of days, you pass some of the fragments. Well, if you only have a tiny stone, often all you need is one treatment. Man, you're done. And it's quite safe, and it's pretty much universally without any serious complications. But in my case, I had to have it done every single month for 5, 6, 7 months. And so I would check in to an outpatient facility, get it done. I'd be back home in about an hour and a half once the anesthetic wore off. Next day, good as new, back at work full time. Well, little by little, the chips started getting smaller and smaller. And finally, After the last one, which was I think number 6 or number 7, I suddenly found myself a couple of days later getting short of breath when I would walk. Now that's a feeling I've heard many of my patients through the years tell me about, but I've never experienced personally until this moment. In fact, when this all happened, I was actually riding my bike about 5 miles a day. Nowhere near what some of you do who are really gifted and have enough time and athletic ability to go, many dozens or more miles. But it was enough to keep me reasonably physically fit. And shortness of breath was just not part of my vocabulary. Well, it turned out a couple of weeks before that, my wife and I, who's also a physician, had H1N1 flu. And we got our flu shots, we always do. But that particular year, it didn't really work as well for many folks, and many people got it. We had recovered enough that went through this procedure, no problem, a couple of weeks later. But immediately checked myself into the pulmonary critical care specialty clinic at our hospital, where they did a chest x-ray and looked like viral pneumonia, could be bacterial, patches all over my both lungs. We talked about, you've had these surgical procedures. Could this be a blood clot? Could this be pulmonary embolus with little fragments? That's a bit unusual in terms of the way the x-ray looked. But we decided, well, let's do a CAT scan on your chest just to be sure. That's a lot more precise. Now, the normal way we do a CAT scan is to inject dye, and that really is the best way to do it. Problem is I'd had so many kidney lithotripsies that my kidney function temporarily at that moment was absolutely not normal. It wasn't terrible, but it was not normal. And giving me dye at that point would have imposed a significant risk. So we decided collectively to do a CAT scan with no dye, just to see, does this really look like pneumonia? Or if it really looks like it might not be, let's give you the dye anyway and take our chances that it might hurt your kidneys, but so be it. Well, you guessed it. Even today, looking back at that CAT scan, with every specialist that I personally know at my institution who was kind enough to take a look afterwards at the films, there's no way you can read that CT as anything other than really looking like bronchopneumonia. So I got put on antibiotics. Every day I would check back into the clinic. Wasn't seeing patients because in case I had some weird bug, we didn't want to risk any patient getting some kind of a pneumonia infection. And all this kind of was playing out over the next several days until suddenly, one morning, I'm sitting at home, walked down, we live in a couple-story house, walked down to the first floor to get a cup of coffee. My wife, who's also a cardiologist, was already at work, and all of a sudden, I can't breathe. I mean, I really can't breathe, and feel like I'm gonna pass out. Immediately feel my pulse, and it's about 100, 110, it's regular. I have absolutely no chest pain. No other symptoms except I can't breathe and I feel like I'm gonna pass out. Immediately, my brain says, you dummy, you've just had a massive pulmonary embolus. That's got an odds of dying of about 199 out of 200 with standard therapy, with a massive blood clot suddenly blocking off most of the blood flow. That means a survival of about 1 in 200. Those aren't good odds. So my first thought was, I'm the EMS director in this region. I got my cell phone in my pocket, got myself to the ground. I got to call 911. That was a no-brainer. My second thought was, that's not a good idea, because I live about 12 or 13 miles from the major medical center where I'm privileged to work in the center of Richmond. And we've got about a dozen community hospitals, all of which are really excellent between where I live and the facility where I work. But the problem is at the time, in 2015, the only hospital in the entire central part of the state that could put patients on heart-lung bypass in the emergency department was the one I work at downtown. Now, here's the problem. We had set up, over the last 5 years before this, a system in our hospital and in our region, in our EMS system, whereby at our facility 24/7, we could take a person in shock with a massive blood clot in their lung and put them on heart-lung bypass within minutes within the emergency department. One of the few places at the time in the country that actually could do that. And we were, at the time, doing emergency ECMO on about 100 patients a year. So we had teams that were really well experienced and very quick at doing this. And we rarely lose a patient with this procedure. And the problem is compounded by the fact that I was concerned that if one of my medic units got a hold of me and I was still alive, and they attempted to sedate me in order to put a breathing tube down in my lungs, a procedure we call intubation, that it would not be a pretty sight what would immediately happen. Because our experience was that anyone who is in shock with a massive blood clot in the lungs, as soon as you give them the sedating drugs and the drugs to paralyze and relax the muscles, a procedure we call rapid sequence intubation, or RSI, that what happens is it drops the pressure on the right side of the heart. When that happens, the person immediately goes into a loss of pulse in cardiac arrest. And if you can't get them on ECMO within literally minutes, they're not going to survive, at least not in our experience. So this little animation which I created really was going through my head as I was really in those seconds trying to figure out, do I dial 911 or not? Well, I chose to, instead of dialing my own system 911, to hit the speed dial for my wife. And what I said to her was, I've just had a massive pulmonary embolus. Call 911. You're going to get the operator in the city, because our medical center is in the city of Richmond. We live in the county next to it called Henrico. As soon as you get the 911 dispatcher, ask them to transfer you to the county dispatch to dispatch an EMS unit, set up ECMO, heart-lung bypass, in the emergency department, and block a cardiac OR, because if my diagnosis is correct, I'm going to need a trip to the operating room to take that blood clot out as soon as I'm on ECMO. Well, that's my side of the story. Now, if my wife were here, and unfortunately she was going to be here, and it would be kind of funny to hear her side of the story in a sort of weird way, because her side of the story is completely different. When she tells the story today, her phone rang, she saw it was me, she picked it up, and all she says she heard was, or something close to that. But interestingly enough, ladies and gentlemen of the jury, she called 911 in the city, asked to be transferred to the county, told them that it was their medical director that thought he had a massive blood clot, gave them the address, gave them the combination digital lock, by the way, good investment, on our back door, set up ECMO in the emergency department, got our pump team set up, and got a cardiac OR blocked. Interesting. Huh. All that out of a couple of ahas. So a few minutes later, one of my firefighter medic crews arrives at my house. They get in the back door, and they find me lying on the ground, cyanotic, and for the lay people, that means I was blue as could be. I was pale. I was in shock, no question about it. My pulse was about 120, it was regular. They couldn't even get a blood pressure on me. But I was able to talk. And I said to them, and by the way, they couldn't even register a pulse to pick up the amount of oxygen in my bloodstream. That's how little flow there was through my lungs at the moment. So this is what I was worried about, blood clot blocking up, which is really what it did. And if they had given me any drugs to try to intubate me, it probably would have precipitated an arrest. So the real issue that was at the top of my mind was, where's my crew going to bring me? Fortunately, I could still talk. And as I've mentioned, we have wonderful community hospitals. As an EMS medical director, our guys over here, we have these wonderful facilities that have different capabilities, but in general, they really provide outstanding care. But in my specific case, for my specific problem, if my diagnosis was correct, and fortunately it turned out to be correct, I really didn't need the nearest hospital. I needed a specific procedure. That was the only shot that I had. And so where I really needed to go was downtown to our facility. We have about a 900-bed hospital. We're the tertiary care center for the region, have an advanced post-resuscitation service. We cool about 100 people a year. Huge emergency department the size of 2 football fields. It's 100 beds, almost 70 faculty, 40, 50 residents. And most importantly, we have an 18-bay resuscitation unit that is absolutely state-of-the-art. We had just built it a couple of years before. And so my question was, am I going to get my crew to bring me where I need to go? And so I blurted out to the crew captain, who knew who I was because I lectured to them every week, just like you guys do, I'm sure. And I said, you got to bring me to VCU. They've got ECMO set up in the ED. They've got a cardiac OR waiting for me. At which point there's silence. And he says, Dr. Rowe, I hate to tell you this, but based on the regional EMS protocols that you medical directors write, oh, that hurt. Oh, that hurt bad. I got to bring you to the nearest hospital because you really look like crap. You can't do that. I'll die. Wait a minute. You're my medical director. Are you giving me a lawful order? Now, I was in the Army. I know what a lawful order is, Colonel. And so did he, thank God. Are you giving me a lawful order to like bypass, 12 hospitals to go to your hospital? And I said, yes, sir, I am. That's the last thing I remember. At that moment, my brain checked out. I was still alive and conscious. And in fact, all the way downtown, from what my crew told me afterwards, I was able to talk. My pulse was 120. They couldn't get a blood pressure. Nothing had changed. And I show up in the emergency department. I don't remember anything. If my wife were here today, she would give you all the gory details. But bottom line, from what I've been told, my whole team was there waiting for me. It was quite a event, apparently. And as soon as I got put to sleep with the RSI drugs to be able to intubate me, that was it. My pulse was gone. And I found out afterwards that, yes, my team did great CPR on me for about 10 minutes until the lines got put in, and at about minute 9 or 10, the switch got flipped. 9 or 10 minutes after I arrived in the ED and I was on ECMO, pinked up, good blood pressure, off to the OR. And in the operating room, ECMO, by the way, is what was put on me. You put a large catheter in an artery, usually you use the legs, at least for emergency ECMO, and a large catheter on the venous side. And you can do ECMO in different ways, but the type that we do in someone who's in cardiac arrest or shock is a form of ECMO where you take the blood from one side and you put it in the other, you put it into the arterial circulation. And the machine itself oxygenates the blood. And it essentially takes the place of your heart and lungs, and it allows procedures to be done on you without your heart actually having to function or your lungs having to function for that period of time. Yes, I got a big dose of a clot buster drug called TPA and a big dose of a drug called heparin. But as you'll see in a moment, places like ours have discovered that rarely are they enough to dissolve that clot quickly enough to save somebody's butt if they're in shock from the get-go. And so off I went to the operating room for a surgical embolectomy, and that's what got taken. It's an actual photograph of what got taken out of my pulmonary arteries. And you can see from the photograph taken with a drawing by our surgical team that both my right and my left arteries to my right and left lung, respectively, were fully, or about 90–95% plugged up. Now, why don't drugs alone save most of these people? And the answer is because when we use drugs in the past, today we do angioplasty, we put stents in for patients having myocardial infarctions or heart attacks. The coronary arteries, when a clot forms in a coronary artery, they're only a couple of millimeters thick. And a clot buster drug can only dissolve about 70% of those clots. I've shown you in the photograph what a clot coming out of a coronary artery in a person with a heart attack looks like in terms of its size. And this is to scale. 70% is all that we can open up. When you've got a massive blood clot in the lungs, it ain't gonna happen, at least in the majority of cases, that you're gonna get enough blood flow quickly if their heart is stopped. So what happens in the operating room, this is not me, by the way, they weren't kind enough to say, hey, we're gonna get one for Joe if he survives this. But this is a procedure called embolectomy, and basically, it's like the birth of a, I don't even know what, but this is a big blood clot coming out of the lungs. Isn't that pretty impressive? Wow, yeah. When I teach my students and my residents and my paramedics about this, you know, it's like one picture kind of gets you to understand that you really need, if you're gonna have a shot at saving somebody with this type of a problem, you really need an advanced system that has all of the abilities to quickly mobilize an entire, literally a village that it takes to save a person's life. So what happened briefly in recovery, I got all kinds of wonderful friends and buddies and colleagues. My firefighters gave me one of the fire hats with all their signatures. I have a t-shirt that every rescuer that was involved in the entire chain signed their name to it. It's something I'll absolutely treasure because it really is important. My attending physician, a guy named Pete Moffat, came to visit me in the ICU on post-op day 2 or 3. I had just been extubated, and I was off the breathing machine, able to talk, and he showed up one night, and he said, you know, how you doing? And I said, Pete, I'm fine. And he said, you know, I'm the guy that intubated you. And I said, well, thank you. And I shook his hand, and I said, I don't remember any of that. You know, apparently I was talking to them in the ER, but, you know, magically my recollection, because I was in shock, was really zero. You know, once I got loaded on the EMS ambulance at my house, I didn't remember anything until after I woke up in the ICU. So Pete turns to me and he says, you know, I'm really glad you're grateful that, you know, I played a role in saving your life. You know, in a couple of weeks, my yearly evaluation by you as my chairman, it's a true story, is due. And you know, I was kind of hoping that this would factor into, so, you know, sometimes you gotta see the humor in things. Well, after Pete left, my wife, Mimi, who was at my side, literally slept in the ICU for the first couple of days. She didn't want anybody to mess me up after getting that far. She turned to me and she said, you know, the word on the street is that the medic crew that brought you in, the senior crew captain paramedic is really upset that he's in trouble. I said, what do you mean he's in trouble? He saved my life. And she said, no. The word is that he's very concerned because he's going to be criticized. He didn't intubate you in the field because you were in shock and you couldn't breathe and your oxygen saturation levels were, on the floor. And I said, well, if he had tried to do that, I would be dead because it would have immediately caused me to go into cardiac arrest. And during a 25 minute trip to the hospital, plus 10 more minutes put me on ECMO, I wouldn't have survived that. And if I did, I wouldn't be mentally, back to normal, which thank God I was. And she said, yeah, I know that, but he's really concerned. I said, get his butt in here. I need to take care of this right away. Next night, the fire chief got the crew in, and a senior medic came in sort of sheepishly. I shook his hand. I said, thank you so much for playing an important role in saving my life and taking the order that I gave you to bring me downtown. And I said, the word is that I hear you're concerned that you might be criticized because you didn't intubate me. And he said, well, yes, sir, that's been a concern of mine. And I said, well, if you'd done that, you would have killed me. And he looked at me and he said, what? And I explained to him what I explained to you, that our experience has been pretty clear that every time you give the RSI drugs to somebody with a massive PE, they arrest immediately. And you better be ready within minutes to put them on ECMO. Oh my gosh. And word quickly spread throughout the community that really what he did in not intubating me was absolutely pivotal and critical to saving my life. So I turned to him and I said, now you tell me why did you not intubate me when you're an RSI trained medic, highly experienced, and you're dealing with somebody that is in shock and can't breathe and as blue as could be, and you can't even get a blood pressure. And he turned to me and he said, Doc, because you could talk to me and answer my questions correctly all the way until I got to the emergency department. And to me, that's the mark of a well-trained healthcare provider, in this case a paramedic. When we wrote ACLS back in the early 1990s, that iteration, Rich Cummins and I put a preamble in, and it was actually Rich's idea, brilliant that he was and is. And the preamble basically was a response to, at the time, a lot of criticism that we were getting nationally for AHA guidelines being like a cookbook. And Rich came up with the idea, and we wrote together in the preamble that a lot of folks look at advanced life support algorithms as a cookbook, and medicine, is an art. It isn't fully science. And a lot of folks have trouble with this notion that there's really, a recipe. And so what we wrote was, yes, it's like a cookbook, but we expect you to be a thinking cook and to be able to use your judgment when necessary to be able to make appropriate decisions. So there I was in the ICU for a few days, then on telemetry, into rehab, returned to work. While I was out of the office, by the way, American College of Cardiology reminded me that I had agreed to write a book chapter for them on cardiopulmonary resuscitation. So, and why are you a week late? And I said, well, I have a good excuse. I died last week, and so they cut me a little break, and I was able to get the chapter in a few days late. The most important thing to me personally, since silly as it sounds, since it really represented my being fully back to normal again in terms of my life, was being able to go through all the FAA procedures, about 2 pages worth of additional tests for what I went through to get on full flight status, which thank you, FAA, I was able to earn back. So anyway, the American Heart Guidelines in 2015 acknowledged that ECMO has a place, And most importantly for our community, I was deeply troubled and haunted by the fact that my life was saved because I was able to pull rank, if you will, and ask a crew to do something that our protocols really prohibited, which was bypassing a nearer hospital. And so in the months after my recovery, I worked very hard with my colleagues, surgical colleagues, emergency medicine colleagues, critical care, and we put on actually programs for our 2 large community hospitals. And today we have 3 ECMO centers, so that we now have better coverage throughout our greater Richmond region. And I feel very strongly that this is a highly technical procedure. If you don't have a team that can do it very expertly and very quickly, and you don't have the surgical or the interventional radiology backup to then get the clot out quickly, it's all going to be for naught. And so I feel very, very strongly that this is really where communities, at least large metro areas, need to go, and large metro/suburban areas need to go. But that this is not something, at least in the immediate future, that I can see every hospital really should be in the game doing. It's a very costly thing for a very small % of people who are unlucky enough to have this kind of a problem. And so I very strongly believe in regionalization. And with other colleagues at American Heart, we're beginning a dialogue of how to potentially help foster further regionalization of post-cardiac arrest type centers for highly advanced procedures. We have ECMO guidelines in our ED that are derivative of the AHA. We have now 24/7 in-house what we call a pump team alert and a PERT team alert. This is something a lot of our larger hospitals in the country are now doing, so that we can quickly mobilize resources to determine exactly what therapies need to be done and to execute them. So bottom line is we learned a lot about this condition and about what it takes and what communities need to do to offer this kind of literally life or death saving kind of procedure. We've done a lot to train our medics to help them identify individuals who are potentially pulmonary embolus, massive embolus type patients. We're very committed to getting the patients to an ECMO center quickly, sort of like trauma, more load and go and do what you can en route. High flow oxygen procedures that are pretty common called CPAP may not be helpful in this case, may actually be harmful by blocking the return of blood to the right side of the heart. Avoiding intubation in the field if you possibly can, if the person can still talk. And then again, having an ECMO center to transport patients to with early notification so they can have everything set up and ready to go. And so bottom line is I'm very, very grateful to have benefited from a system that I was privileged to play a role, not the only role. It's a whole village that it took and takes to really put together very sophisticated systems like this. But you know, it sort of taught me that all my life I've sort of felt as an educator to some degree. I was sort of in the business of sales in the sense of selling or giving education to my students, to my residents. But this little event made me realize I'm also in purchasing as well. And bottom line is I think hospital capability and experience can matter for certain conditions. Regionalization of complex life-threatening conditions can save more lives. I hope I've inspired some of you who play roles in your community or who may aspire to play roles can look at what communities like ours are doing to further up the game of what can be offered rapidly for selected patients who have otherwise unsurvivable conditions. I've tried to make the point that this is not a procedure, at least for the immediate future, that I foresee every hospital getting in the game of, and to urge you to build your support and help your regional EMS system to develop this kind of capability. And the final thought is that in the 2 days that I was intubated and on a ventilator and basically drugged out so I didn't know what was going on, when I woke up the next night, the night that the paramedic supervisor, problem was identified by my wife, she said to me, while you were out of the office for the last couple of days, we had 2 more patients with massive pulmonary embolus that were put on ECMO. I said, really? 3 of us? In like 48 hours? And she said, yeah, really. And I said, oh my God, what happened? And she said, well, they were both women in their 3rd trimester of pregnancy, both in our hospital with complications of pregnancy. And the obstetricians were, trying to nurse them along another day before they did a C-section to allow the baby to mature as much as possible, to give the baby the best chance. And hours apart, having nothing to do with either themselves or us, just random events. One of them was on the OB floor and suddenly went into shock, couldn't breathe, and had a massive pulmonary embolus. Had ECMO put on in the bed on the OB floor. I'd have paid good money to watch that. I mean, in an ICU or in a really busy trauma emergency department, we're used to doing things quickly, but OB floor, oh my God, unbelievable, they did it. The other one, the lady was in the ICU, and they got her stable enough to go to the OR where she got put on ECMO. And I said, oh my God, what happened? And my wife, Mimi, said, both women survived. And I said, what about their kids? She said, both kids, perfectly fine, normal, healthy, emergency C-section. So within 48 hours, 5 lives got saved by having a system of care that works. Thank you so much.